outset, I'd like to thank AOS, Dr. Namrata and Dr. Sumit for giving me this opportunity. And my first DALC was in 2004. I watched the first DALC being done by Dr. Shariz Daya. And over the 17 years, I've had several oops moments in this DALC, and I find it the most difficult surgery in all the intraocular surgeries that we're doing today. So it's a no-win situation even now. So I'm going to share one of my oops moments. This was a case of a macular corneal dystrophy in a 26-year-old patient who had very severe photophobia in the right eye. You can see that we had to take several pictures to get at least one picture right. And the left eye, it had keratoplasty done by me 4 years back, and he had excellent vision. He also had a phacofoldable done 1 year back, and his best corrected visual acuity was 6/6 after cataract surgery. So we decided to do a DALC in this patient, and so this is a case of what happened on the table. And since I was a little bit wary about getting a good bubble, I decided to have a good tissue as well as use a Fleringa ring just in case I have to convert into a full thickness penetrating keratoplasty. In these situations, I always prefer to do a superficial keratectomy, particularly when you're not dealing with a thin cornea. And then use a 30 gauge needle to do an air injection. And you can see that is perforated and gone into the anterior chamber. Really didn't bother me because decided to continue with the another one more injection. I softened the eye by doing a paracentesis, and now I got a nice big bubble. But unfortunately, it didn't go up to the periphery, but nevertheless, I had quite a large bubble, so I decided to de-roof the bubble. You can see after once, I again went back inside. I think that was a mistake. So now I have punctured the Descemet's membrane, and there was an aqueous outflow from the punctured area. So, and the bubble had become very small. So I decided to just inject an is viscoelastic to separate the Descemet's from the rest of the stroma. But the viscoelastic went into the anterior chamber. So then, since I knew there is a space, a potential space, I decided to go ahead with a manual dissection. And using a blunt Vanners, I went through a manual dissection. And you can see I'm able to bear the Descemet's in some areas. But whenever I closed in on the area of the perforation, there was a leak, and I was not able to continue with it. So I sutured the area of the perforation in the presence of some stromal tissue, so that I can go ahead with the manual dissection. But as I was doing it, I noticed the original bubble seen here. You can see the original bubble here. And so I thought, why not try once more opening up that bubble and finding the potential space. So I punctured it once more. And this time, I think I succeeded, and I got a very nice large opening, and I was able to inject viscoelastic and separate the Descemet's from the rest of the stroma. And then from then on, I think it was an easy task. I used the Vanners, blunt Vanner scissors, to open up the anterior portion, the anterior stroma, actually in posterior stroma, and completely bare the Descemet's. So in this case, because the air bubble was not complete, I had to do some manual dissection all around and make sure that the area surrounding the bubble was also, the tissue around it was removed, so that there won't be irregular astigmatism after suturing, and also create a ledge so that the suture will be well placed. And finally, I removed the area where the suturing has been done, and injected air, and placed a same size graft. So in a case of a perforation, it's always better to use a same size graft, because then the chance of a double AC formation is much less. So this case went off uneventfully after this, and I was able to get a very nice bubble, which was, you can see the graft is well placed. And post-operatively, patient did well. You can see the area of small perforation there, but and the ASOCT also showing area of some disturbance in the area of perforation, which cleared up over a period of time. So this is a first day post-op picture, but by 6 days, you can see the cornea cleared up pretty well. And the best corrected visual acuity in 1 month was 6.9. He had a clear and compact graft, and the specular count was about 2000. So, a little bit about intraoperative perforation. The incidence is quoted somewhere between 4.4 to 39%. And if the perforation is small or a medium-sized perforation, you can still go ahead and do a complete the lamellar keratoplasty, as been very beautifully shown by Dr. Himanshu. Such lovely cases he had. And then, but if it's a very large perforation, you have to convert into full thickness penetrating keratoplasty. So patients who are at high risk of perforations are patients with advanced keratoconus, previous hydrops, and deep dense scars, patients with pellucid, macular dystrophy, and therefore it's very important that you have an ASOC to make an important decision whether the patient can have a problem on the table, to assess the density of the scar, to assess how much of Descemet's is involved in post-hydrop scar and so on. So it will give us an idea whether we can do a manual DALC or a big bubble DALC, because the chance of perforation is more in a big bubble DALC, but particularly in patients like this where the risk of perforation is very high. So where these patients can definitely go in for a lamellar DALC. So this is one of the complications which can happen at double anterior chamber. If there is a double anterior chamber, it can be handled in several ways. If it's very small, the separation can be watched. In case of a larger separation, air injection and positioning the patient supine will usually get rid of it. But if there is a recurrent separation, you can use either a C3F8 gas or an SF6 gas to retain the bubble for a longer time. But in cases with persistent double AC, you change the graft to a smaller size graft and use a venting incision. So the take-home message of what I learned is don't puncture the bubble more than once. Keep the eyes soft during dissection. It's very important, like Dr. Rajesh also mentioned, it's important to do a paracentesis before continuing with your dissection. And also using the Mellis technique, use the air to guide your dissection and avoid any very sharp instruments. And in case of perforation, don't give up, because you can start dissecting from the opposite area, like Dr. Himanshu showed in some cases. And as much as possible, if the endothelium of the patient is good, try to do a lamellar procedure and probably keep PK as a last resort. Thank you.